right, ready to start. Welcome to the first annual UCSF Global Health Economics Colloquium. Glad you're all here. Sorry for the little bit of a late start. We have BART and transport problems. I think people will be trickling in, but wanted to get going on the morning. We have a great day ahead of us. We'll start with some welcomes from our sponsors. I'll talk about that in a moment. And then move on to a review of global health economics research at UCSF, and then a keynote talk by Steph Bertozzi from the School of Public Health at Berkeley. Your program says that Steph will start at 1 a.m. He has informed me that he prefers to start at 11 a.m., so we will do that for him. We then have a lunch, which we're calling a free lunch, and those of you with an argument with that don't have to eat lunch if you don't want to. And then from 1 to 3, we will have workshops on cost effectiveness analysis, on behavioral economics, and on workforce. And the room assignments for that are indicated on the agenda, but we'll review that later. We also then will have a panel on hot topics in global health economics to finish the day, moderated by Dhruv Kazi. Kazi, I want you to, where are you, Kazi? There you are. Can you explain our Twitter situation?
Well, there's a Twitter handle on that should be on your handout, and if you guys are tweeting, then we prefer that you use the hashtag. It says GHECon 2013. Thank you.
And it'll be on my slide, so you'll see it again on my first slide. Before we go into the formal welcomes, I would like to thank a lot of people who have been so instrumental in making this happen. First of all, the GHS leadership, which has supported the Global Health Economics Consortium throughout, and this colloquium in particular, and also the Institute for Health Policy Studies leadership. I want to give a huge special thanks to Devin McCabe, who has orchestrated all of this brilliantly. Thank you, Devin. And also to Lena Libatique, Jay Sullivan, Teresa from Global Health Sciences, and other GHS and IHPS staff, and our volunteers. Thank you very much for volunteering. It all made this come together. Thanks very much to Kazi for the panel, but also just for having the idea that we could do a whole day on this and have a lot of fun. And so I think I'm going to owe Kazi something for suggesting that, assuming we have a whole day, which I think we will. And also thanks finally to Elliot, Jenny, and Joanne, who are the workshop leaders and have put huge effort into preparing some really fun hands-on workshops for the afternoon. With that, I would like to invite Jaime Sepulveda, the Executive Director for Global Health Sciences, to start the proceedings with a welcome.
Thank you, and good morning, everyone. Real pleasure to be here. Let me add my words of welcome to you all on behalf of Global Health Sciences. It's really a great pleasure to co-sponsor with Claire and with Jim this colloquium. Last night, I gave a talk on precision medicine, and the title suggested by my dear friend Keith Yamamoto was Precision Medicine for the World. So I had to give a lot of thought. What is it that I can say about precision medicine for the world? And as you know, precision medicine for us at UCSF is becoming a real priority and a flagship. And the notion of being able to bring the omics revolution to personalized medical care for individuals sounds really attractive. Being able to provide, as Sue Desmond calls, the right medicine at the right dose to the right patient at the right time really makes a lot of sense to me. But oftentimes, the cost component or price tag is forgotten. What are the premises and promises of precision medicine for the world at large? How can we make of this movement, a rising tide that lifts all boats. You're all familiar with the principle of Moore's law, which predicted the doubling of transistor in integrated circuits every 2 years. And in practice, this has meant the doubling of computing memory every 18 months at 1/2 of the price. Healthcare costs in the US are the opposite of Moore's laws. Healthcare costs in the US are doubling every 13 years, now reaching 18% of GDP, $2.5 trillion per year, more than $8,000 per capita. Korea has a larger life expectancy than the US, with a fraction of the price tag. So, while information technology is getting faster and cheaper, health technology is driving cost upwards. The only exception I can think of is genome sequencing, which has come down 6 orders of magnitude in a few years to a mere $1,000 nowadays. So clearly, the US model of expensive, inefficient, unequal healthcare is not a model to be exported. Precision medicine, in my view, should aim to achieve better quality of care at a lower cost. And it ought to incorporate the social and economic determinants in its definition and scope. My mantra in global health sciences is to develop affordable health solutions delivered for measurable impact. So that metric is, to me, both in the affordability and in the measurable impact, fundamental. Science, technology, economics, and policy, STEP, need to be blended in order to create those affordable health solutions. And this is the reason why I'm so enthusiastic about GHECon, this initiative, as part of the Global Health Sciences Federation. I have been fortunate to interact with brilliant health economists early in my career, with Gene Jamieson in the Investing in Health World Bank report, and then the Disease Control Priorities Project, with José Gómez de León, who actually created Progresa Oportunidades and the notion of conditional cash transfers, with Steph Bertozzi, who founded the Center for Health Economics at the INSP in Mexico, with Julio Frank, who designed the Seguro Popular, this universal health insurance, and now with Jim Kahn and this extraordinary group of health economists in the Bay Area. My dear friend Steph Bertozzi will be giving the keynote later today. He's one of the smartest people I know. And his arrival as a dean of the School of Public Health at Berkeley is great news for all of us in the Bay Area. I have great expectations that UC Berkeley and UCSF will find a way to collaborate much more closely together. And GHECon, frankly, could be and become one of those bridges we need to build. I was asked to make an announcement. Speaking of Dean Jamieson, Larry Summers and Dean Jamieson developed a commission, and we have several commissioners in that group: Gavin Yemen, Colin Boyle, other UCSF, Richard Feacham, have participated in that group of economists revising the notion of investing in health 20 years later. So Global Health 2035 will be launched next week in London. The Lancet is publishing this 60-page report. It's a special issue of Lancet on investing in health 20 years later. Global Health 2035 is the title. And Larry Summers will be here on December 17th, sponsored by us, to launch in the Bay Area this important commission report by Lancet. So you are all welcome to come Tuesday, December 17th, 5 p.m. to 7 p.m. In Parnassus. And we will post this note outside. So with that, let me again express my thanks to GHECon for this great initiative, and Claire and I are very enthusiastic about the symposium and colloquium. My best wishes.
So now I get to introduce the director of the Institute for Health Policy Studies, where I have had my home for the last quarter century. Sorry, you're afraid to say. Claire Brindis has been hugely supportive.
Thanks, Jim. And also I want to say a very special thanks to Jaime Sepulveda for his incredible vision and leadership with the global health sciences. Not only is he the catalyst and the energizing bunny, but he is bringing together a number of us who are very, very committed to the issue of the translation of research into improving the health and well-being for the public across the world, not just in any one particular village. When Jim came to talk with me about the potential for launching this group of like-minded individuals, I was very enthused. In the 40-year history of the Institute for Health Policy Studies, health economics has been part of our DNA, along with social, behavioral, and policy sciences, along with clinical and other kinds of sciences at UCSF. And what is really remarkable about seeing all of you here today is the incredible energy that we're tapping into, not only at UCSF, but really in the Bay Area. Because the problems and challenges that you are all working on really require a village of like-minded individuals who bring together many different disciplines in launching types of solutions that are so timely and so necessary. Jaime has pointed out to you the incredible expenses and costs to society related to the disparities as well as the perverse incentives in our current healthcare system in our country. And it's really within our lifetime that we will see the tremendous need for much more data and economically driven solutions as policymakers are trying to make smarter decisions related to fewer resources and harder problems to solve. So I was very enthused about having this consortium, having this colloquium as being the first of many activities. And I anticipate that through today and through future activities together, that we will really create a synthesis and a catalyst for change, bringing together many different individuals who already are working and devoted to these issues, tapping into that energy both at UCSF, at UC Berkeley, at Stanford, and other institutions within the Bay Area is really key if we're going to solve some of these very challenging problems. I have been very fortunate that I've seen in action the power of having economic analysis. And about 15 years ago, Jim and I worked together when the California Wellness Foundation was about to launch a decade's worth of work in the area of teenage pregnancy and pregnancy prevention. And what they approached us about was, could we look at what the cost savings were with positive deviance? That is, young people who are responsible about their contraceptive use. And I was very fortunate that I could turn to my dear colleague Jim to say, let's look at the analysis of how many births are averted by responsible teenagers. And that analysis became the cornerstone for a decade's worth of work by this foundation. Later, I've been very fortunate to work with colleagues through the OBGYN department, and I'm very happy that Heike Bocanegra is here with us in the evaluation of the Family Pact program that serves almost 2 million low-income men and women in California. And again, Jim Kahn, Diana Green Foster, Tonya Biggs, and a number of other colleagues have been so instrumental in being able to show return on investment for this very important service for low-income men and women in California, which is a model not just for our country, but for worldwide. As I think about today and the conversations that I've had with Jim and Jaime, and the issue of precision medicine on our campus, we've also been talking about a concept of precision health policy. Precision health policy, as we are beginning to define it, is the use of evidence to inform locally adapted health strategies and interventions with the goal of achieving large and lasting health gains. The concept entails the integrated consideration of evidence on disease epidemiology, intervention costs and effectiveness, delivery systems capacity, and financing. In addition, precision health policy will incorporate local constraints, really thinking about existing communities and commitments and priorities. For example, issues of equity, issues of disparities. And in contrast with precision medicine, which is really based on the exponential growth in data about genomics and personal health, the concept of precision health policy is really targeted to communities. Communities, when we talk about communities, we're defining them not only villages, but districts, provinces, countries, and not just individuals, as well as really thinking about how do we deal with making very important decisions when sometimes our data-poor environment, the imperfect epidemiology, the uncertain applicability of interventions is really available to us. So we want to really marshal the energy of thinking about precision health policy as it drives many of our current and future activities, not only here at UCSF, but in the Bay Area, hopefully tapping into solutions that will have a worldwide impact. So, as many of you may know, my last name, Brindis, in Spanish, means to make a toast. So I make a toast to you with the anticipation that the informal and formal conversations that will take place today with the expertise of our panel members and of our keynote speaker will help to launch a synergistic approach for more collaborations and more useful research that will help to make a difference. Thank you so much.
I'm going to do the first talk in a set of 5 talks. After I do this quick overview, you're going to hear from UCSF investigators about their specific projects, but I thought I would just set the stage with a broad look and some quick snapshots. I call it Overview of Global Health Economics at UCSF, Diamonds in an Expanse of Diamonds. And for those of you who are Twitterites, tweeters, here you go. That's our Twitter connection. So get that down if you're going to do that. Why do I say diamonds in diamonds? I know that there are superb economics at UCSF. They're somewhat hidden, nestled in a much larger expanse of superb biomedical research, but equally impressive. This morning I'd like to give you a brief tour. This is illustrative, not exhaustive. We have much to be proud of. I think a superb foundation in health economics on which we can build. However, until now, health economics has not been treated as a distinct and coordinated enterprise, but has been taking place in a number of separate silos. There's much to be gained in coordinating. We can combine and expand skills, foster collaboration and share resources, create collective visions for how we want to apply health economics, and of course, to facilitate this, to expand funding opportunities. First, a definition. What is global health economics? I define it as the use of economic methods to understand the determinants and effects of health. And the determinants, of course, include healthcare. I have divided this world of economic methods into two categories. These are a little bit soft categories, but I think useful. The micro, that is disease or intervention-focused methods, and the macro, which are usually, but not always, system-focused. In the area of micro methods in global health economics, we have cost of illness, for example, studies of efficiency, cost effectiveness. An important new area is behavioral economics, and I should note that the Presidential Medal of Freedom was just awarded to, among other people, Bill Clinton, Bill Cosby, and Daniel Kahneman, one of the co-founders of behavioral economics. So wide recognition now of the importance of this field. On the macro side, delivery structure, who are the providers, who's the workforce that is providing the necessary health care, what are prices, how do we allocate resources, and so on, all the way through to burden of disease as measured in disability-adjusted life years, and the relation of health to wealth. These are all important topics, and a number of areas have been, as I will show you, have been addressed by UCSF investigators. What's the scale of health economics at UCSF? Well, I did a little experiment. I went into Google and typed UCSF economics and got 291,000 hits. Pretty good. Of course, I don't know exactly what that means. I went into PubMed and I typed the same search term and I got 973 citations. We'll be having a small party when we hit 1,000. I also have looked in UCSF profiles and found when I searched on economics more than 500 individuals, unique individuals, on articles that at least mention cost or economics. That's a lot of people. I don't think we really have 500 people at UCSF who do economics. So we've instituted an effort as part of the Global Health Economics Consortium, which I prefer to pronounce GHECon as in get your geek on. Your economists will understand that joke. We have been using snowball sampling, and we're still pursuing this. We are looking for people at UCSF, faculty and senior staff, who use economics in current research. We love, obviously, to network with people who may have done economics before, but what we're trying to get into the core of GHECon is people actively doing economics. We found more than 40, and still counting, still rising. These are individuals across all 4 schools and in many departments. A large proportion have done international work or have strong interests in so doing. They address various health conditions, use various economic methods, and focus on different parts of the world. In your packet and online, you will find a description of about 26 or so of those people and their areas of interest, their methods, and so on. And there are also going to be posted complete profiles of all these individuals. Here's a quick sampling in chronic disease. Kazu, I mentioned earlier, does cardiovascular CEA. Wendy Max does cost of illness. I'm not going to read all of these names, and it's not a complete list anyway, but just to give you a flavor, Jenny Liu, who's going to be presenting on behavioral economics, does that and other areas with a lot in malaria. I do cost effectiveness and resource allocation. Elia Marseille does similar work. George Sawaya, who will be presenting, works in reproductive health. Leslie Subak, Joelle Brown. Renee Shaw, is an emergency physician, also does work on surgical services. Nilan Sekri-Feacham works on health systems, as does Dominic Montague. Workforce, Joanne Spatz and Tom Hall have been working in that area for many years. And again, this is just a sampling. But what I'd like to do now is move to some specific projects, just 6 projects that give you a flavor for the kind of work coming out of UCSF in this area. The first is cost effectiveness of genotype-guided antiplatelet therapy, APT, in acute coronary syndrome. This is work that Kazi is in the process of revising for imminent publication. The background is there are many drug options for APT, and genotyping, a new technology, may be able to guide the choice of drugs. The study found that genotyping with a drug called ticagrelor, I'm sure I'm mispronouncing that, is clinically superior but more costly than clopidogrel with an incremental cost effectiveness ratio of $30,000, which is in the U.S., for those of you who don't know, pretty attractive. Ticagrelor is without the testing is even more effective, but at an additional cost of nearly $53,000 per QALY gain. As this slide shows, as the cost of genetic testing goes up, the genotyping strategy becomes less cost effective, that is, costs more per QALY gain, and in contrast, the non-genotyping strategy looks more attractive by comparison. The implications of this study are that genotyping may improve the cost effectiveness of antiplatelet therapy, and this is seen in other areas as well, and ticagrelor, I should have practiced that. For all patients, it will be economically reasonable in some settings. So keep your eye out for this study coming out soon. This one here is resource allocation. This is work from my team with Elliot Marseille, Alex Goodell, and also Ali Mirzazadeh and Mohsen Malakinejad, who are here today. And what we're trying to do here is move beyond the single cost effectiveness analysis and offer users a web-based, user-friendly, but powerful and flexible tool to look at a variety of different interventions in a particular setting. This particular version is calibrated for Ghana. And what the user does is opens up these boxes and adjusts the coverage levels for different intervention strategies, and can also adjust those by specific population if they click here. So there's a lot of flexibility to adjust the strategy to allocate the resources differently. And that produces a series of scenarios. I happen to have two up here, but it can go on. And it leads to predictions on HIV prevalence, as well as a variety of other outcomes like AIDS deaths and so on. So this is our attempt initially in HIV, and we hope to extend it to other diseases, to provide a practical to one of the techniques to realize precision health policy. Next, I'm going to talk about a study on the rollout of rural health coverage in Shifan County, Sichuan, which Neelam Sekri-Feacham was involved with. China's rural universal health coverage policy covers hospital stays, primary care, and outpatient care. It's financed mainly by the government, but also individuals contribute a small amount. And when this was studied in Shifang, the findings were that it increases access to health services for households, and that's the hope, of course. Overall expenditures rise due to this increased demand, as well as the switch to higher quality services. It improved, even though it increased demand, it also improved affordability and financial protection for the average household. Variations in co-payment levels affected the utilization of outpatient services, but not hospital care. And interestingly, despite higher co-pays, patients chose higher quality township health stations rather than the less well-staffed but less expensive community health stations. Also interesting was that there was an essential drug list set up and an improved drug procurement, and that led to lower drug costs despite the fact that people had more resources. Moving here to another area in economics. This is economics of tobacco control in California. This is work by GHECon members Lightwood, Max, and Sung. A couple of different findings here. One is that the California Tobacco Control Program, which of course costs something to implement, yields reductions in smoking levels, which in turn yield health benefits, which save money. And if you look, there is a very substantial net saving. And starting in 1991, the annual savings have been growing. This is the best estimate. These are the confidence bounds. Savings to the California Control Program, we're talking in the tens of billions of dollars. So a huge savings from this program. But then the next question is, well, what if you keep the policy the same or change it? And here we have the base case. You won't be able to read these numbers right here. I'll just give you a sense for it. What if funding is cut in half? Well, these negative numbers mean negative savings means cost goes up. But if you increase the tobacco tax and thereby further decrease smoking, you get even more savings, and here you see the overall increase in the savings with an intensified tobacco control program. This work has been instrumental in the state of California for its very strong smoking and tobacco control programs, has really answered a lot of concerns. I also remember an important study that was done that showed that restaurant receipts did not go down with the implementation of the restaurant smoking ban. In fact, they went up. Again, critical research coming out of the tobacco group on the economics of tobacco control. This next study is one by Renee Shaw, Access to Emergency and Surgical Care in Sub-Saharan Africa, the Infrastructure Gap. The background is that it's critical to recognize the gaps that may hinder emergency and surgical care. So she and colleagues took data from two sources, the Service Provision Assessments and the Demographic and Health Surveys, and found that the situation in terms of the infrastructure was pretty dire, my word. Running water and electricity in these facilities was available only a quarter to half of the time. 24-hour emergency care, 19 to 50% of facilities across countries. Unexpired drugs and current inventory of drugs only in 18 to 41%. Supplies for infection control and safe hazardous waste disposal, less than 50%. Training and supervision, 14 to 76%. In this graph, you can see the results by country, Ghana, Kenya, and so on. The blue line is for hospitals. Hospitals look a little better on these measures. Health centers, the red bars look a little worse. The implications, if we're going to provide emergency and surgical services in these settings, we need to build the infrastructure. John Peabody did a project, reported recently on a project on financial incentives and measurement to improve physician quality of care in the Philippines. The background here is that pay for performance, which is a big idea in health economics, of course, is understudied both domestically and internationally. Also, quality is difficult to assess. So John and colleagues put together an RCT where they randomized facilities to either the physicians getting a bonus based on the quality, volume, and satisfaction measures for their care, or there was an increase in access through better insurance for the hospitals in that arm, or control condition of status quo. The outcome measure is a tool that John and colleagues have developed and validated called clinical performance vignettes, which ask physicians what they would do in certain circumstances using an open field approach, and then the answers are coded. And this has been shown in prior work to relate very well to using actor patients, and of course is far less expensive. They found that both interventions improved quality by 10 percentage points. You can see here the blue and red bars are pretty similar, and they're all better than the control condition, although the control condition at 36 months did have a bit of a jump there. Implications, the potential of this kind of intervention to improve quality and to use these kinds of vignettes to track whether quality has been improved. That's a quick tour of 6 studies. As you can see, I think quite varied and all important contributions to the field. Our mission in GHECon is to promote the use of state-of-the-art economic analyses to increase the impact of public health and clinical science to advance the health of people worldwide. Through fostering global access to information and tools, we promote precision health policy, as Claire described, the use of evidence to inform locally adapted health strategies and interventions. This is something we pursue through technical research, broad collaborations, and innovative teaching and training programs. The full GHECon mission is in your packet, and it has a little bit more detail. I encourage you to look at it when you have a moment. That's what I wanted to do by way of overview, and what I'd like to do now is invite Jenny to come up and talk about her behavioral economics project in Nigeria.
Thanks, Jim, and thanks, Jaime and Claire, for the invitation to share with you an exciting project that we're doing in Nigeria, but also I'm actually very excited to learn about other projects going on here at UCSF, so this is very exciting for me. I've also been asked to highlight the behavioral economics portion of our study, which in a nutshell, for those of you who have limited exposure to behavioral economics, it's incorporating insights from cognitive psychology into standard economic approaches to understand ways in which people seemingly behave in irrational ways, but also to develop interventions based on people's reactions to here and now contexts, environments, and cues to foster better health behaviors as well as better health outcomes. So in our study in Nigeria, we're looking at the introduction of malaria rapid diagnostic tests. And these are not new diagnostic tests, but they are relatively new in terms of introducing in developing countries. And Nigeria has one of the largest burdens of malaria in the world. So we're going to be looking into how we can introduce a new behavior, which is diagnostic testing, amongst customers who presumptively treat themselves for malaria. Okay, so the behavior we're interested in is malaria is treated presumptively, which means I feel like I have a fever, so I'm going to run to the nearest drug shop and buy myself an anti-malarial drug. And most of the time, I don't previously go and get tested. I don't previously go and get a blood test to see if I actually have malaria parasites. I feel the symptoms and I think it's malaria, and so I go out and buy a very relatively inexpensive drug. It can range from a few cents to maybe a few dollars. Okay, well, what is the problem with that? We think that there's a vast amount of overtreatment, as people have sort of reported that there's a range of symptoms for which they self-treat for malaria. This includes having bad dreams, having backache, my knee hurts, so a variety of things. And right now, we're deploying our basically last drug in the fight against malaria. Artemisinin combination therapy is the most effective first-line drug, and there's evidence that there is resistance emerging and spreading. So in lieu of a replacement for artemisinin combination therapies, we really need to think about getting this overtreatment under control. Not to mention that, where the donor community is heavily subsidizing these new artemisinin combination therapy drugs, and overtreatment just wastes a lot of the donor monies that are going into this. And lastly, we all care about health, so the non-malaria illnesses that may actually be occurring are not being treated, and so may actually lead to more severe outcomes. So in Nigeria, most people seek care in drug shops. So these are kind of like 7-Eleven shops. They sell all sorts of types of drugs, over-counter and prescription medicine, as well as Cokes and recharge cards and a lot of other things. So we are going to be focusing on these drug shops in our study and looking at this new policy change in which the Ministry of Health has recommended that malaria be first diagnosed either through microscopy, which can only happen in a lab, or these new rapid diagnostic tests, which are very simple to use. You take a little small prick of your finger, get a blood drop, and then you place it on this cassette and wait about 15 minutes for a result. 1 line is negative, 2 line positive. So it's very similar to the rapid HIV test. Okay, so but what are our research questions in this setting? So first, we just don't have any idea of the extent of overtreatment. So what is that magnitude? Is it a little? Is it a lot? How severe is the problem? Second, how do we get individuals to change their presumptive treatment behavior? This is what they've done for a long time. This is what they know. This is what all of the social media messages tell people to do. If you think you have a fever, please go treat yourself for malaria. Well, we think maybe a simple intervention in terms of introducing diagnostic information about your malaria status may immediately give you an understanding of what the appropriate behavior should be. So this, in the second research question, we're looking at a pure cognitive pathway based on rational decision making. So this is what you would expect. You get information about your malaria status, then you decide, yes, I need to treat myself, or no, I don't treat myself. So that's very standard. Okay, but here's where we think our behavior economics principles can come in. How can we foster better behavior in terms of people listening to the RDT results and actually following the right advice? So for a lot of people, if we think overtreatment is really a big problem, they're going to be trying to wrestle with a new behavior, which is, the RDT tells me I'm negative for malaria. That means I should not be taking my drugs. This is rather counter to what people are normally used to doing. So we're thinking about a way in which we can nudge people to prod them into not taking the malaria drugs if they're negative. So how do we reinforce that message? Now, there are a couple of complications. One is this is a new behavior, and we all know new health behaviors are hard to instill. And second, individuals may be relatively uncertain about this new technology. They've never seen this rapid diagnostic test before. They don't quite understand what it's telling them, and they might just default to their normal behavior and take the anti-malarial drugs. So in order to answer these three questions, our methods in a nutshell, a little bit complicated, but I'll try to go through it very quickly. I want to emphasize this is a pilot study, so we were really trying to test if this is even possible in a setting in Nigeria. It was our first time working in Nigeria. So we worked in 2 cities, in Ibadan and Ogbomoso, north of Lagos. And what we did was we placed our surveyors outside drug shops, and we screened them for eligibility as they were exiting. And so anyone who actually reported buying a malaria drug was asked to participate in our study. We gave them an RDT on the spot. We went through a battery of questions about their care-seeking behavior, trying to elicit a better idea about what they normally do. We played a risk preference game, basically a lottery, to assess their risk profiles and determine how risk-averse they were. And the idea was thinking to correlate, see if risk preferences is associated with treatment-seeking behavior, as well as any adherence to the RDT results later on. And we also recorded the drugs that they purchased on the spot. So the key to remember here is that these are people who have just exited a drug shop, bought a malaria drug, and presumably are taking or treating themselves for malaria with the drugs that they purchased. We then sent them home with their RDT result on an advice card that looks like this, that says what their status was, as well as what they should be doing. You don't have malaria, please do not take your anti-malaria drugs. They will not help you get better. And then one day later, this is where behavioral economics intervention came in, which is, imagine you're a patient, you go home with this advice card. Yesterday somebody told you that you should not be taking malaria drugs, even though you felt terrible, you thought you had a fever. Okay, so you went home and thought, okay, well, maybe I'll give this thing a shot. Next day comes by, you're still feeling lousy. I don't know, I'm a little uncertain about what I should be doing at this moment. So what we did was, one day later, after we saw the patients and tested them, we sent them an SMS text message that basically repeated the exact same thing that the results card mentioned, word for word. And it was basically a reminder to the person of what they should be doing. So if you're on the fence about what the right action is one day later, this message was designed to help you, remind you, and help you to stick to the right course of action. And then 4 days later, we called everybody and asked them, self-reported status, how do you feel? What did you do? Which drugs did you take? And that's how we used to assess adherence in the end. So what were our results? Okay, finding. We found that only 4 to 5% of adults purchasing malaria drugs were actually positive for malaria. which was very surprising to us. We expected some level of overtreatment, but not quite this level. I'm going to heavily caveat this and say that this is a non-representative sample. We only sampled at urban sites, and we didn't include children and rural areas, so potentially those areas have higher malaria risk. But still, it was very surprising to us that the positivity rate was so low, suggesting to us that it's probably a lower bound on actual malaria prevalence. And so we're repeating this later on, actually this year, to see if we can include a little bit more representative sample. Number 2, okay, so what happened to the information shock about the diagnostics that the RDT diagnostic gave you? If you were given information about your malaria status, did you adhere to the right steps? We actually found quite high adherence. We were impressed. Based on the information alone, 73% of people took the right course of action. So that means if you're positive for malaria, you took your malaria drug. If you're negative for malaria, you didn't take your malaria drug. So overall, those two groups averaged out to be taking the right course of action to be about 73%. That's pretty high. Now, let me heavily caveat this again, in that because it was a very small study, a very small pilot, we didn't actually have a control group to assess against. So we're assuming here that the default behavior, the counterfactual, was that you were intending to take your malaria drug because you purchased one. I mean, that's not totally far off, but we have no hard evidence that that was the default behavior. Should the patient if the patient had gone home without being tested. Now, an interesting finding here in a corollary analysis that we did was that people who chose lottery games with lower risk, so we asked people to choose amongst a series of lotteries to assess their risk tolerance. So we found that those who were more risk averse actually showed higher treatment adherence. So that to us was very interesting because we expected the opposite. Now, we're trying to figure out why that is, and that just creates more work for us. But it was a very interesting result that risk tolerance actually helps to enhance adherence among some people. Okay, what happened to our behavioral economics intervention? So we sent an SMS text reminder to everybody, to randomly selected half of the participants 1 day later after they got their test results. And we found through a variety of regression controls and specifications that adherence actually improved by at least 10 percentage points and up to 15 percentage points, depending on what kind of analysis you're doing. And the treatment effect on the treated, excluding the people who didn't see the actual test result but were sent one, is actually about the same. So to us, that was very encouraging that a very simple intervention could actually improve adherence pretty well, I would say. Now, we're repeating this in this year to see if that result actually holds over different populations. What we did in the follow-up survey was we asked people, well, what did you think about the text? Why did it work? Because we want to understand what the pathway is. And most people responded, it reminded me of the test result and it reminded me of the treatment. So that, to us, was very encouraging that the reminder was working toward the exact behavior that we were trying to target. So very quickly, the conclusions and implications. Overtreatment of malaria, quite extensive in Nigeria. But we need a more representative sample. So we're repeating this study this year in rural areas and including children. The results forthcoming. RDT acceptability and treatment adherence, pretty high. But mind you, in this study, we gave the RDT for free. So it's not clear what would happen if people had to pay for the test. So we're actually doing that this time around. and we'll see what the results are. And then in terms of the risk adherence, risk aversion and adherence correlations, this just led to more questions. Well, would message framing actually help to improve adherence amongst the others who were sort of lagging behind? And endorsement messages was one thing that we're considering testing out in the future. And then finally, SMS reminders were a really cheap way to increase adherence by quite a large amount. But actually, it might be difficult to operationally implement in a larger program. So we have to think about the actual policy implications of this. Overall, a broader rollout of RDTs in Nigeria actually faces legal barriers. So there's a supply side, entire supply side provider behavior that's yet to be studied, and that will be put into our list of things to look toward in the future. But in the meantime, we are already starting conversations with the Ministry of Health in thinking about how RDT should be rolled out in the private sector in Nigeria. And I want to acknowledge our partners in Nigeria who are very helpful in executing this study, as well as Sabide Modric at Stanford and our entire team at UCSF. So thank you.
All right, good morning. I'm going to talk for a few minutes about taking a slightly different view of the global health thing and focusing on the international workforce and the flows of health professionals across countries. This is somewhat related to work I've done for the International Council of Nurses at looking at the causes of unemployment among nurses in developing countries primarily. But for this analysis, we focused on foreign trained nurses who were working in the United States and where they came from and what kinds of roles they hold in the United States, which is the receiving side of the immigration puzzle. We know one reason many registered nurses leave the countries in which they were educated is because of poor employment opportunities, poor working conditions, and low earnings where they live. And so the United States, the UK, Australia, and a lot of other countries become very attractive workplaces for them. So those are kind of the push factors in those countries. When they get here, what do? And what are their roles in our labor force? So, and this is work with Michael Gates, who's down at San Diego State, and Cheryl Jones, who's at University of North Carolina. So we wanted to start with just how many internationally educated nurses do we have in the U.S., and what has been their pattern of immigration over the past several decades? What kinds of employment do they have? And then what do we see in their earnings? Because there has been some concern that hospitals or other employers might treat internationally educated nurses differently. There might be some wage discrimination, or perhaps wage differences might reflect differences in education or language skills that would be legitimate reasons from an economics perspective to have differential pay. So this is just your snapshot of our internationally educated RN workforce in the U.S. based on the 2008 National Sample Survey of Registered Nurses. Unfortunately, that's the most recent data that we have that explicitly asks nurses where they were educated. So no surprise for anybody who's been in a hospital in the past 10 years that half of our internationally educated population is from the Philippines. In the Philippines, that is essentially an export product for them. It is intentional that schools are educating significantly more nurses than the Philippines could ever employ on its own. And strategically, that then results in a lot of remittances being returned to the Philippines. What's interesting in a state like California, where many of these nurses have settled, is now we can look in the data and see the second and third generation, their children and their grandchildren becoming nurses in the U.S. A few years ago, we were looking at community college data, and among men in nursing, the dominant racial ethnic group of that population was young Filipino men entering nursing, who I suspect many of whom had mothers, aunts, or other family members who immigrated in nurses and said, wow, that's a great career, I'm going to do that too, and didn't feel a gender barrier surrounding that. But other countries where we have a lot of nurses coming are Canada as our number 2 source of nurses. India, which is actually a fairly new emergence, that really is only over the past 10 to 15 years that we have seen a lot of Indian nurses coming to the United States. The UK, not surprisingly. Back to Nigeria, we actually import a lot of nurses from Nigeria, which in some respects is a shame because Nigeria needs all the registered nurses it can keep. Many from Korea, and personally I have advised a number of fabulous Korean nurses who have come to UCSF for their doctorates in nursing. And then a whole variety of other countries. You kind of think of the country and we can find them here. So when did they get licensed? This chart shows the decade in which nurses were licensed, and as a benchmark, the US decade of education is here. So you can see from the Philippines, we had a lot of immigration of Filipino nurses in the 2000 to 2008 period, which was a period where there were widespread reported shortages of nurses in the US. Not surprisingly, international recruitment rose. But in comparison, say, India, where I had mentioned that the immigration of Indian nurses was a relatively new phenomenon, you can see that over, nearly 60% of nurses who were educated in India immigrated to the US just within the past 10 years, essentially. Anecdotally, when there was the dot-com crash in the kind of the early 2000s, there were a lot of Indian engineers working in Silicon Valley on H-1 visas. And at about that time, many of them had to go home. They had to go back to India. And you started seeing articles in the Indian press about them wanting to come back to the US, and employers and educators saying, ooh, but if we educate their wives to become nurses, then they can get back to the US on their wives' nursing visa. And so, it wasn't like engineering companies were trying to encourage this to get their H-1 workers back. It was really more of that the people who'd returned to India had developed a community in the United States and wanted to return. And then, of course, a group of business people in India, there's a lot of educational entrepreneurship there, saw the opportunity and went with it. And so it's kind of interesting. In contrast, Canadian and UK immigration has been much slower in recent decades than it was, say, 20, 30 years ago. So what is their employment status? This is going to be very closely related to age, which of course is related to the decade in which nurses immigrated. The employment status of nurses who were educated in the UK is much lower, but that in part is that many of the nurses from the UK immigrated more like 30 years ago, so they're really pushing towards retirement age now. U.S. educated nurses tend to be very stably over time. About 85% will be working in nursing, about 2/3 full time. You can see the employment rates for Filipino nurses and Indian nurses are significantly higher. Part of that's age, that they're younger, and younger nurses tend to work more, and part of that may be other factors related to family and work needs and so on. We looked at their employment settings, and we thought these were actually very interesting. Basically, all nurses, except for those educated in the UK, for these 5 other major countries of origin, or 4 other major countries of origin, are significantly more likely to be in the hospital setting than US educated nurses. Now again, part of this is age. The classic model is that a newly graduated nurse will begin in a hospital. And for many nurses who are immigrants, they are recruited by hospitals. Hospitals have the money to go out there and do intentional recruitment efforts overseas. So it's not really a surprise then that 87% of the Indian educated nurses in these data were working in the hospital setting. They were relatively new immigrants. The hospitals had probably recruited them. They probably actually had recruited them with a number of requirements about the length of time they would have to be employed in the specific employer that recruited them, or they would lose their visa. There is some work that I've done with Polly Pittman at George Washington University, where we looked at unethical recruitment practices, and it is actually quite stunning the number of nurse recruits who had to put collateral down to receive their visa processing. Their international recruitment basically meant that their family had to put down sometimes up to $10,000 in collateral to guarantee that they would stay working in the employer in the United States. There were some nurses in the survey work that we did who reported that their documentation, their immigration documentation, was withheld from them, was held by the recruitment company, and that they did not actually have access to their passport or their visa. So if they wanted to leave, they actually physically could not because the companies were holding their paperwork. And this was a much more significant risk for internationally educated nurses coming from developing countries. It was almost never reported for Canadians or Brits, and it was reported not all the time, but the rate was 10% or something like that. I mean, it was high enough to really alarm us and absolutely violates the global code. So you can, the settings here are not surprising at all. And then the lower two lines are the job titles that you see registered nurses holding. The nurses, again, from India and the Philippines are much more likely to say that their job title is staff nurse, which would be reflective of their age. And then the nurses from the UK and the US are somewhat more likely to be in administration, as are Filipino nurses, because we have such a wide age range and experience range of Filipino nurses. So then we looked at their earnings, which was really kind of the thrust of what we wanted to get to. And what was interesting to us, the survey reports data about their principal job total annual earnings, and then we use their hourly the number of hours worked per week and number of weeks worked per year to compute out what their hourly wage would be. And so we have both of those numbers here, and they are asked to report that for their primary nursing job as well as their other nursing positions. So as you can see here, interestingly, U.S. nurses are reporting lower annual earnings, and you might say, well, maybe the U.S. nurses are more likely to work part-time, but they also are, their computed hourly wage is lower than all these other nurses, even though they're typically older, except for as comparison to the UK nurses. So what's going on here? You know, are Filipino nurses and Indian nurses so good that we're actually paying them more? They are more likely to have bachelor's degrees, so that is plausible. So we did some multivariate regression work to control for a lot of these other characteristics of nurses. So it has, see, I'm an economist, I have to have the geeky regression table. And so get your geek on. So, you know, here are the data here. Well, when you start controlling for these other characteristics, the first column is a model that doesn't have any variables to control for the job title of the nurse. And then the second column does control for the job title that the nurse holds. So if you don't control for the job title, you find basically that gender, education, experience, and urban residence washes out almost everything for all the internationally educated nurses. In fact, Filipino nurses here have significant at only the 10% level lower wage, and Canadian nurses might have a significant at the 10% higher wage. So, you know, not a lot of difference once you control for human capital. When you add to that controls for their job titles, then basically the only international effect that holds up is that Canadian nurses are paid a premium. And so these differences in wages are almost entirely human capital differences, which are really important. Now, I know some other folks who are doing work on looking at language competency and how that interacts with it. I think Ed Shoemaker at Trinity University, and then somebody else who's at Penn, I believe, are doing some interesting work trying to look at that and delve into how the language proficiency plays into these results. So there you go. I already said all of these results. Thank you.
George Sawaya, and I have worked together many years ago, not recently, but maybe again soon. George is a professor of OBGYN, as it says, and he's going to talk about cervical cancer screening.
Good morning, everyone. Thank you, Jim, for organizing this, and I certainly owe a debt of gratitude to some of our prior speakers, specifically Claire and Jaime and Jim, for setting this up, because everything you've said, I think, will be reflected in this particular content area. So cervical cancer is preventable, but it still causes about 250,000 deaths worldwide each year. The thing to know about cervical cancer, it occurs at a fairly young age as far as cancers are concerned. So when it does occur and cause mortality, it translates into a lot of life years saved, and it translates into a lot of disruption of families. In the U.S., cervical cancer is fairly uncommon, about 4,000 deaths per year. We have a different problem in the U.S. than we have globally, in that we tend to overscreen, and that is harmful and it's quite expensive. In the U.S., it's about $6.6 billion are spent in screening and treatment of pre-invasive lesions. And of course, that's for a fairly uncommon disease. But overscreening is also harmful because it prompts invasive procedures, biopsies that are done without anesthesia. I'm responsible for many of those, as well as treatments that have their own intended harms. One of the harms of treatment have been consistently preterm birth and preterm labor amongst women who've had cervical treatments. before they have completed or begun childbearing. And that prompted the U.S. Preventive Services Task Force in 2012 in their report to Congress to identify the optimal use of HPV testing, human papillomavirus testing, which is the causative agent in cervical cancer, for which there's a test now, its role in cervical cancer screening to be really quite scrutinized and optimized. And that was amongst 3 priority areas. One is screening for chronic kidney disease, the other is screening for prostate cancer. So this really held a prominent place of importance from the point of view of the task force because of its potential harms. The goals of our study, and our study is just beginning, is to actually do a very comprehensive analysis of screening for cervical cancer that uniquely takes into account the harms of screening, which have not generally been taken into account. Our first specific aim is to measure preferences or utilities for current and novel cervical cancer screening strategies, and the novel strategies I'll talk about in just a moment. Trying to understand a little bit more about women's experiences and perceptions of screening. We then aim to estimate the range of reasonable options for screening average risk women by identifying these novel strategies that provide at least similar or improved health outcomes compared to current screening strategies. And the third is to try to get a little more personalized and a little more precise by determining whether or not we should have different screening strategies for high-risk women, and those might be women who are HIV positive, or for low-risk women, and that might be women who have been vaccinated against HPV. So our methods are to use focus groups, and we've completed all of the focus groups, to try to understand the factors that may influence women's desires for various screening strategies. Then we're going to do a cross-sectional study where we're going to use a very state-of-the-art computerized preference elicitation tool to measure utilities using the time trade-off method. Then our modeling strategy is a Markov model, which has been refined over the last 15 years. This based on the natural history of HPV infection amongst populations and how that infection can either go away, which they often do, or can progress to precancerous lesions, and if those are untreated and unidentified and untreated, lead to cervical cancer, and then by extension cervical cancer death. Our outcomes are what traditionally have been used by the U.S. Preventive Services Task Force, which is an outcomes table, which is very transparent, theoretic cohort of women, if you screen them in certain ways, what kind of health benefits you might achieve, the number of women that you might avoid dying of cervical cancer, and then the health harms, which might be false positives, overtreatment, unnecessary biopsies, and any other things that we think are credible harms. The good thing about outcomes tables is, as I said, they're transparent. The bad thing is that they have no weighting factor. We have no way to say how much false positives and biopsies are worth avoiding a case of cervical cancer. And everyone generally looks at these tables and says, well, look at that. And they don't have any way of putting it together. So we propose having a single metric, for the first time really, a single metric that tries to incorporate both benefits and harms, and that metric is known to many of you as the QALY. And this is using the utilities we measure in specific aim 1 to weight the outcomes so that we have single metrics and can use a baseline to then compare all of our outcomes for all the different strategies on the same playing field. We're also going to look at the effect of immunocompromised HPV vaccination on risk of high-grade precancerous and cancerous lesions, and we're using a case control study methodology using data from Kaiser Permanente, Northern California, which has a very comprehensive database, so we can actually look at vaccinated outcomes, not from trial data that are optimized, but from the standpoint of effectiveness, not efficacy, so that we can actually see the real-world impact of vaccine and then model that. Here is our analytic framework, which it's a busy slide, but I wanted to show you because it only took me many, many weeks to come up with this to embed into our grant. So here's what we're going to do. Estimate the life years for average risk women using the BASE strategy. The BASE strategy is not no screening, because that is not what we do in the U.S. We do screening, and screening we've chosen every 3 years with cytology alone as the base. Pause. Lots of thought about that. Could we change it to no screening? Yes. Would that give it an international scope? Yes. Will that be done? Probably, if we have more funds to do that. But certainly once you construct the model, making these changes can be quite simple. Measuring and applying utilities. Would these utilities be applicable, the ones we measure in the US, in the Bay Area, to the country? Maybe, we hope so. To the world? I don't know. Unknowns. But then we will measure qualities, and then on this side we'll look at the novel strategies and do the same things and make this comparison with this single metric, and we'll also do the same thing with these higher risk and lower risk women, vaccinated and immunocompromised women, and make this comparison. And then we have all the outcomes that I explained to you. Does that make sense to everyone? I hope so. So we will then also do the economic analyses to help guide policymakers about if they were going to choose a strategy, which one might they choose for their particular setting. Very intrigued with Jim's slide showing how you can use a website to change these parameters to fit it to different settings, and we will take that as a suggestion. The strategies that this is what's great about a colloquium, right? You see things and say, wow, why am I not doing that? And the answer is, I should. So we're looking at different strategies, single tests, concurrent tests, sequential tests, using what is currently available on the market in the US. We'll also look at this colposcopy-only strategy, which is kind of saying, why don't we treat cervical cancer like colorectal cancer, where you can just get a colposcopy, which is the reference standard diagnostic test, every 10 years, rather than getting these screening tests every year or every 3 years. No one has really kind of looked at that, but it seems like quite a credible thing to do, and maybe that would be more maybe women would prefer that more, to get a lot less frequently than just a lot more frequently. So, we have an urgent need for innovative approaches that complement our traditional approaches, randomized trials. We simply cannot do randomized trials of all of these different strategies, and people simply have to get very comfortable with models. They have to if they're going to move the needle forward. We can't do randomized trials of everything and every strategy. There are enormous opportunities and challenges in defining these optimal screening and preventive approaches in both the US and the non-US settings, but for very different reasons. One is for the over-screening, the other is for the under-screening. And again, I'd like to say, and I'm going to put my hat on as a member of the UCSF Center for Healthcare Value, and I want to say that word at this podium. We do have that center, and I'm in charge of the training component of that center, but the economic implications of healthcare interventions can no longer be ignored in any setting. I don't care if it's the US, I don't care if it's in an underserved setting, we simply have to be aware of these because they do cost, there's this, I think, an ethical responsibility of the society to steward resources responsibly. I want to thank all my co-investigators who are off on a great start, on a great journey. Miriam Cooperman, Karen Smith-McHugh, and Steve Gregorich, and our collaborator Mike Silverberg at Kaiser Permanente in Northern California. And our modeler is actually at the University of Minnesota, Shalini Kulasingam. And the funder is the NCI through an R1 mechanism to remind you all that actually the NCI does fund studies like this. You just have to be persistent, and you have to make them realize it is a great addition to their portfolio. So, thank you.
Leslie Wilson is a real health economist, is a PhD in health economics, as did Joanne and Jenny. So I'm sort of an imposter with MD and PH. And Leslie and I have been talking about health economics for that whole quarter century I've been around. So thank you, Leslie, for talking about drug pricing policy.
Hi, I'm also glad to be here and glad to see such a nice audience here. Today I'm going to talk about the impact of generic drug policy on drug pricing in Argentina. And this project actually got started when I was at an SMDM meeting, Society for Decision Making. And we had a global health group. And our goal was really to get to inspire and help new health economists in developing countries. And so this project came out of that meeting. I wrote a Pacific Rim grant, and we have a partner in Argentina who was just starting out in health economics, and then one of my students, and worked together on this project. The background was that during the early 2000s, Argentina experienced a severe recession, and this resulted in 60% of the country's residents losing their health insurance, and also the prices of drugs skyrocketed at that time. So in response, at the very end of 2002, Argentina passed what's called the generic law. And this was to improve the access to medications for their public. And this was, the law required prescribers to prescribe medicines by their generic name or active principle rather than their brand name. And we've seen this kind of drug policy here in the United States, but it's a little bit different in Argentina because in Argentina there's really no such thing as a generic. They have what's called similars, not biosimilars, but similars, and that's because the similars are not really tested to see if they are the same as the brand in terms of their work. However, it's generally felt by the public that they're of pretty good quality, the generics, but they aren't really tested. And so the response might be different from the public based on this knowledge. In addition, even though the prescribers were required to prescribe the medicine in the generic name, once the person got to the pharmacy was not required to give them that generic. A patient could say they wanted something else and they were free to give that to them. So we weren't sure if this would work the same as in the United States. Purpose then was to determine the economic impact of this policy on both brand and generic drug pricing and also utilization. So we wanted to see if we would see an abrupt change from what the prices were before and after the drug policy, and we wanted to see if there was a differential effect on brand versus generics. So our methods were to look at an interrupted time series design. And this design is looking at a large number of points of time and the prices before an intervention or a policy, and then look at a large number of points after that intervention and see if there's an abrupt change at the point of the policy or intervention. And so we had data on the WHO essential drugs with prices in Argentina from 1995 to 2010. So we had enough points before and after the drug to do this kind of design. We had 191 drug products and 33 drugs by active ingredients. So this consisted of like a number of generics and one brand for a bunch of different active ingredients. So the analysis for this interrupted time series design is a random effects regression, and we compared those price trends before and after 2003 when the policy was really going into effect. Our independent variables were time, the policy itself, number of drug products on the market because we thought that might have an effect on what was going on, and then the brand and generic status of the different drugs. And the dependent variable was price. We used a log price, and we inflation adjusted that by using real prices. We also controlled for policy effects diminishing over time and some other things which are put into the model. So this is just a really sort of ridiculous picture of all 192 drugs. And just gives you an idea of the timing here. The economic crisis happened in 2000. You can see that in general, these drug prices started to go up. Then there was the policy effect in 2003. And you can see that in general, prices started to go down, but it looks kind of variable and it looks like it's not necessarily sustaining. And that also shows that when you do these interrupted time series, you can't just look at it and see if there's a real effect. You have to do analysis. So we did our regression, and our findings in general were that on average, over the whole time of the period, both before and after the policy, the overall drug prices rose significantly by 3%. And also over the whole time period, the brand prices rose 21% more than the generics. And then looking at our policy effects, we found that post-policy, the real prices, inflation-adjusted prices of the generics declined by 2% annually. But the post-policy effect was that the brand drugs actually increased by about 1%. So there was a differential effect in prices between the brands and generics. So for this part of the study, we had very little information on drug utilization. But we did have some. So this is just to show you some of those. Since then, we have information on the drug utilization of all these, so we'll look at the relationship between price and volume. But here, this gives you an idea both of this difference and also that things can vary by particular types of drug products. Is it a necessary drug that you can't avoid? Is it a market that's very heavily, lots of drugs in the market, those kinds of things. So this is for drug fluoxetine, and on this side is the prices, and then looking at the utilization. And you can see that the red line is the brand drug, Prozac, and in both graphs. And you can see that after the policy effect, there was a big increase in the price of the brand, but the generics had more of a drop and then a stabilization. And so then if you look at the drug utilization, and the red line again is the brand, you can see that the Prozac volume dropped, though, in relation. And you can see that generally most of the other generics had some drop in utilization, but sort of more of the stabilization, except for one. The yellow line was one of the generics, and this generic seems to really just have the market share. And so these will be differential, and the drug industry in Argentina is a very big, important part of their economics as well, national economics. So you can see that there may be some variation by type of drug and drug product, and so we will be able to look at that in more detail later on. Though in our general regression, the market, how heavy the market was, did not have an overall effect. So in conclusion, it seems that this generic drug policy did have an effect. It seems to have dropped in general the prices, but those might vary by the specific drug. And also, it seems that the generic prices dropped most and the brand prices rose, but it seems like the total cost may have gone down because the utilization seemed to decrease. And then just so that we're beginning to analyze the volume effects now to go along with this.
Thanks so much, Jim, for the invitation. Thanks, Honey, also for your support of this agenda. Thanks to Eric Gooseby, who was instrumental in what I'm going to talk about today, and thanks to my boss, Talmadge King, who supports this kind of research in the Department of Medicine. So I am neither an economist or I'm a student of economics now, which I've learned as working in this collaboration. So I'm going to focus not on our study, but how we interface with the economics group here at UCSF, and also with Harsha Murthy, who Harsha has been absolutely essential to this collaboration. So SEARCH stands for Sustainable East Africa Research and Community Health. It's a multinational, multidisciplinary research consortium that was put together to test bold community health interventions to inform policy makers. Our first study is aimed at showing how we can shut down new HIV infections based on the knowledge that antiretroviral therapy stops HIV transmission at an individual level, providing a health benefit for the recipient, but there's equipoise about rolling out antiretroviral therapy everyone globally at the population level. So our study, in essence, was designed to answer two broad questions. First, can antiretroviral therapy shut down new HIV infections with a test and treat strategy? And if so, what are the secondary gains, maternal child health, tuberculosis, education, household earning power? What's the best way to do it, and what would it cost? And secondly, can efficient HIV chronic care models be adapted to establish care for other chronic conditions such as hypertension and diabetes? In terms of the role of economics in search, it is central. Absolutely, from the get-go that we put this consortium together, it was front and center. What we recognized when we realized that we had some tools to begin to end the AIDS epidemic, that it was insufficient to convince the ministers of health that this was the way to go, that we needed to provide data that spoke to also the ministers of finance. And we also, of course, recognized that we needed the expertise from economists from the inception of the project, inclusive of the pilot work for this very large study. And the importance of multiple economic evaluations, not just one dimension, but to look at what's the effect of test and treat on the individual, the household, and the community level, to incorporate behavioral economics and incentives, and to look at cost effectiveness, and DALYs. So this is a complicated slide, but what I used to describe the search study to an individual. So on the far left, there's a green zone, good, red zone, bad. So what we used to do in HIV when we had very toxic medications, we'd allow people to get sick, fall into the red zone, and then we'd start treatment and we essentially rescue them. The premise of search is what we should be doing now. We have very simple once-a-day medications for HIV that are very tolerable, is to find people in the green zone, keep people in the green zone. And this not only affects the health of the individual, but when you think, speaking to an audience of economists, what that requires in the healthcare system, you're either gonna have clinics or even less than clinics, or you're gonna build hospitals for people getting very, very sick. This is a cluster randomized study that we're doing in 3 sites, 2 in Uganda, Western Uganda, Eastern Uganda, and the Nyanza province in Kenya. It was a very large study. It includes 32 communities of 10,000 each, so a total of 320,000 individuals. Half of the communities are randomized to receive universal antiretroviral therapy. The other half of the communities are randomized to receive whatever the country guidelines are, which continue to change over the course of the study. We do a baseline census in the communities. We do digital fingerprinting, which is permitted in the cultural setting and by the IRBs. So we know every single person, and then we track them through our community health campaigns where we where we obtain information on HIV, malaria, hypertension, and diabetes, and then we can track linkage to care and treatment. So we're treating everyone in half these communities who have HIV. Our primary outcome of the study is HIV incidence, which we are measuring directly with this, what we're calling efficient community cohort. Our outcomes, I won't list the community health ones, I'll talk more about the ones that are related to economics. So we will be looking at community productivity, parameters such as workforce participation, child labor prevalence, something that is, I'm sure, intuitive to all of you, but what happens in HIV in families when the parents get sick, they can't work, so the kids drop out of school, and then they go into the labor force. So actually you create child labor, and it's been shown when you use antiretroviral therapy, you can reduce that. We'll also be looking at agricultural output, household income, educational attainment, something I think that's very, very important when economists think about what are the consequences of building economic strength and power and keeping people healthy, and of course also healthcare utilization. So the practical aspects, Jim asked me to comment on the incorporation of economics. We have spent 2 years developing search, testing out everything, and we had economic analysis in our pilot phase in order to develop and test instruments. You need baseline and longitudinal assessments when you're writing your grants and looking for your funding. One of the things that's key to the search intervention, it is not a static intervention. In our intervention communities, we're using real-time data to adapt our intervention, and so our economic evaluations also need to be very nimble for real-time adaptation. This requires, of course, you can imagine, careful and ongoing communication for multidisciplinary international teams, and needs to be embedded seamlessly, not a whole separate set of studies going outside of your main study. One of the challenges that we've had is funding bodies have narrow scope, like they only want to do health, or they only want to do this. And we heard earlier that yes, NIH does fund this, but I would say this is something as a community we need to let the funders know that often, except when we have visionary funders, they want to separate it. And that makes it very, very difficult to put your study together. Many large bureaucratic and logistical barriers I won't go into. And of course, there's other challenges, language and cultural adaptations. This group works very internationally. One of our sites, there's 7 different languages. Everything we do, we have to have consent, and we have to translate into 7 different languages. And of course, we absolutely need capacity building for this kind of research on the ground. Jim asked me to give one of the examples, and this is work that we published from one of our pilot studies when we were looking at what do people with high CD4 cell counts, how can we evaluate their productivity? Do they really work more than people with low CD4 cell counts? And this was a cross-sectional study, and Harsha can talk about this more in the afternoon sessions, but we found that those with high CD4 cell counts work nearly 1 week per month more than those with less than 200 CD4 cell counts. And this is in very, very rural areas. And in terms of economics, Harsha was explaining to us, we need to look at how people view investment. And I just want to tell you a really quick story. We just had our DSMB go and meet a farmer who was in our pilot community, who's a head political leader. And one of the DSMB members says, do you really notice anything different now that you're offering testing and treatment? He says, well, I don't know about you medical people. This is what I can tell you. When people found out they could get tested and treated, they started buying more expensive farming equipment. And we keep track of who buys what. So that's what I can tell you. So that was a very real, concrete example of how an intervention can have an effect. The outcome of the collaboration, I don't think our study would have been funded without the robust economic analysis that we had built into the study. We're going to be developing, we have publications, a couple of publications already. We would like to aim towards methods development. We would like to use it, funding permitting, a vehicle for training. And it's a core element as we think about what's going to be next in terms of the search study once that we address this question. In terms of specific economic domains that we are including in search, Jim and Elliot are leading up the cost and cost effectiveness. We're looking at the effect of ART on individuals, households, and communities, being led by Harshal and Daniel Mwai from Kenya. That includes socioeconomic outcomes, and we're also have a component of behavioral economics and incentives. One of the big challenges for those of you who work in global health know, yes, women bear a great burden of healthcare issues, but the men don't participate in healthcare. This is a huge challenge, and we need to figure out how to overcome that, and I think behavioral economics could have some of the answers in that regard. So my conclusions, our economic studies were a key component of advancing our health and our central, should not be add-on to medical research, aiming to influence policy. Our search collaboration is about generating data that policymakers are going to use. We need to work closely to ensure relevant data are being collected. We also need to advance the methods. We sat around with Jim and we're like, you know, to us, that's not exactly important. We're more interested in doing this. And I think we've had some very fruitful discussions. Our DALY is really the best metric that we should be using. And we've tried to challenge Jim and Jim's group on that regard. And we need the funding agencies to support multidisciplinary work. And we need continued capacity building of our scientists for research infrastructure. And this effort is being sponsored by a consortium. We're very grateful for our funders, and I'm very honored to work with many people here in the room on this and around the world. So thank you.
First, I just want to say thank you to Jim Jim and Elliot have worked closely with in the past, thanks to Claire and Jaime for having me here, although I don't know you. It's very nice to meet you today. And I do want to say a special congratulations to Steph for joining Cal. Although I am graduate educated at Hopkins, don't hold it against me, I am a die-hard Cal fan. And I have a very personal request I need to start with, or I wouldn't forgive myself from asking, and that is for anybody here who is a Cal football fan. It's been a very difficult year. If there's any expertise you have in offensive line or special teams, I would please ask you to stop by practice and give us a boost. So congratulations, Steph. We look forward to your leadership at the School of Public Health. And thanks to everybody here. I also want, before I start, to just say this is a little bit different style presentation. I realize that I am a very close collaborator with the economics department here. They have contributed a huge amount to the work that we do at Vestergaard. But this is really conceptualizing the role of economics and really what it means to practice, what it means to taking services and technologies to scale and getting them, as Jaime said, to the right people at the right time for the right price that's affordable. So just to give you a quick background on Vestergaard, we are an international company. We are based in Switzerland. We are built on a humanitarian entrepreneurship model. What it means is that we really look at innovation. We look at innovating technologies that can prevent disease, innovating programs that translate these technologies into health impact, and innovate health service delivery models. As a company, we are built as two businesses. We have a water business and a vector business. We do a lot of work in malaria control. We're the largest producer in the world of insecticide-treated bed nets, and do a majority of the R&D around integration of insecticides into textiles. We have a food security group that looks at productivity, agricultural productivity. And then on the water side, we do work in linking environmental outcomes and health outcomes through water interventions. We work, of course, with WASH, which is Water and Sanitation and Hygiene, and on education programs bringing water. What's really interesting in this space is the integration piece. In the company, the integration piece sits within the water business, which is why you're speaking to me today. And this is the part where health economics can be really, really interesting and play a huge role. And we do a lot of work in the health economics and effective integration of HIV/AIDS work, maternal, newborn, and child health and emergency response. So what we'll talk about today tends to be around some of the work we do in HIV. So just in terms of the way our company deals with innovation, we do deal with technology, development, manufacturing, distribution. We look at scalable service delivery. So every service delivery that we're going to work in has to be scalable. It's sort of one of the core mottos of the company. If you can't do something that will go to scale, then don't do it. Efficient program management. We are a private sector company. We are a for-profit company. So bottom line, whether bottom line means profit, whether bottom line means DALYs averted, means lives saved, we have very personal, programmatic, and global measurements on how well we're doing. And then supportive health policy. To make that work, so you can innovate all four of those things, but really to make that work, you have to figure out the economics of it. So really what underpins this is understanding, can you afford to do all four of those things, right? You can innovate a fantastic technology and it can be effective in the lab, but if you can't afford to get it out to populations at scale, then it will sit in the lab. You can create great service delivery models, but if you don't have technologies or efficient program management, or you can't afford to get them out, then you're stuck again. So the way we look at everything includes economics at all four of the key parts of our innovation. The one example that I'm going to take you through briefly today is a project that we did called the Integrated Prevention campaign in Kenya. In 2008, we partnered with the Ministry of Health, the Ministry of Public Health in Kenya, to see if we could help them meet their very ambitious targets for HIV voluntary testing and counseling. They needed to meet 80% voluntary testing and counseling in a specific age range, 15 to 64, and they were very behind on that target. They also had very low health indicators in that area on child health, maternal and newborn health, malaria. So we worked with them to see if we could come up with an integrated service delivery model to meet those targets. What we did, the Integrated Prevention Demonstration, was a 7-day long campaign that was held in Kenya. We did a lot of social mobilization ahead of time, but we offered voluntary testing and counseling to the population of Lurambi Division of Western Province, and we incentivized them to come by giving them free distribution of a care pack of services, a care pack of health commodities, including a bed net, condoms, IEC materials, and a water filter. We aligned the way we would develop the care pack, did our social mobilization again against national targets. So what were their needs assessment? What targets did they need to meet? And to show that that could be done very efficiently rather than doing it in vertical programming, rather than a malaria program coming in, a water program coming in, and a VCT program coming in, and to show that we could do it very quickly and efficiently without losing quality of the services. So just some key statistics of that campaign. The total population in the area was 51,000. Cost of the campaign was 41,000. We tested in those 7 days 47,000 people, and you can see some of the breakdown there. What we did was we offered voluntary counseling. Whether they opted in or opted out of testing, they received a care pack. Whether they were positive or negative, they received a care pack. It was built in a way that was very confidential and anonymous, so they could go through the system while they were queuing for services. We did a lot of training, hanging bed nets, using water filters, health education training, as well to use their time. And we had some really interesting outcomes. In the first 7 days, we achieved 81% of the target population testing, and you can see testing for the first time was the 81%. So it was a huge achievement for the government. We then had partnered with a lot of institutions and collaborators on a lot of different research. So this is just to give you a taste of the style research we did linked with this campaign. We looked at, can you meet targets? What's the uptake of the water filter, the bed nets? What's the understanding that comes out of that? How many people opted in for testing? That was the first publication there. We did some qualitative assessments on participation. We looked at predictors to linkage of care. So it's not enough that you do a campaign in the traditional sense, a one-touch with the population, but can you get them into care if they were positive? We did CD4 counts on site. We provided the first 3 months of cotrimoxazole on site, and then got them referred directly into the government program. But the interesting part for this group are the health economic studies that we did. We did a series of them. This is the collaboration that we did with Elliot and Jim. And I told them today that I recently saw somebody present some of my data, and it was horrifying. So I was not going to present their data for them. I was just going to highlight a few things that we saw here. That per 1,000 participants, we saw 16.3 deaths averted, 359 DALYs averted, 85,000 in medical care costs saved. And then you can see the breakdown of the rest, some of the highlights here. That we did see a net savings in the intervention itself. The actual cost was about half when you compare it to what you would have done with vertical implementation. But the cost effectiveness and health impact modeling was hugely interesting for us. We looked at modeling the economies of scale. So what happens when you go beyond 47,000 people? Again, if you can't take something to scale, if the economies diminish when you go to scale, it's nothing that you want to do. So this is where you start paying attention to, can you create more gains by going to scale or less? How can you optimize that model in terms of cost? So we looked at that. There's a publication out here. Cost per person served was $41.66 in the pilot or in the program that we did, and it's projected to go down to just under $32 for a scaled up model. You can see some of the breakdowns of where that cost comes from as well. We then have developed out of this, and I haven't included all the studies here because there's a number that has come out, but subsequent to this, some specific questions have been asked, and that is really, what's the economics of delaying disease progression by distribution of malaria prevention through bed net distribution and diarrheal prevention through household water treatment? And what's the impact of delay of disease progression for people living with HIV and AIDS? There's been 2 very interesting articles that have come out in the campaign itself. We identified the average CD4 count for positives at around 550. In a comparative group at the provincial hospital, the average at first test CD4 count was, I think, 346. So you are detecting disease much earlier, you're getting them into the system much earlier, and while that does mean that you start them on antiretrovirals a bit earlier, and there is a cost associated with that, getting people into the health system earlier has a net savings. So I am a firm believer, absolutely, in research and collaborating. But I say over and over and over that we can't do research for research's sake. So research has to contribute to something, and research has to give you information not on how well you did, but on how you can do it better and what the next steps are. And so this is translating the results that we have. If this type of campaign was implemented nationally in Kenya, using the modeling, we would have $28 million a year in antiretroviral costs saved and 2,200 lives from HIV-related deaths averted. So that's interesting if we implement Kenya, but we're always looking further. What happens if you implement in a country like Nigeria? So you can see the differences in numbers. A campaign that would cost $16.7 million would save $67.3 million. And if you model that across all of sub-Saharan Africa, you're talking about a savings of $402 million in antiretroviral costs. And that accounts for 8% of the PEPFAR antiretroviral drug budget, at least it did about a year and a half ago. And that has big policy implications, big programmatic implications. We don't have endless resources as a global network working on HIV. You have to make decisions. As a government, you have to make decisions on what to spend your money on. And while you have a large upfront cost to implement models like this, you have savings over time, and I think that as we go into the challenges we see is a big behavior change for all of us that takes time. So we have some really powerful economic data here. But how do we update policy, change development financing patterns, and then scale up programs? And that, I think, is one of the biggest challenges we've met after this. You know, the first campaign was in 2008. We've been working on this since. We have not yet successfully scaled up the approach, despite all the data around it. And I think it takes time, and as a group of economists and health economists working in the international space, we need to start challenging the way policy works. We need to start challenging the way financing patterns and the way we finance international public health or international health in general. You know, you don't just want to measure how well we do with what we spend, but let's look at how we spend it. So a few key questions that I think is worth it for this group of young health economists working in international health to think about. Some of the three things that you hear a lot if you work in the space, they're the buzzwords, the sexy words to talk about at a public health dinner party. Economics, reality, scalable integration. We've been hearing about integration, taking things to scale for the last 5 years. I haven't seen a lot of it happening. What's the problem? Long-term sustainability. The word sustainability is defined for, if I had $1 for every definition of sustainability, I would be a very wealthy woman. What does it mean? What is sustainability? How do we understand it? And what does it cost? What is the cost of sustainability? I think that's a question we haven't really answered. And then pay for performance and results-based financing. This is something that funders really like to talk about. How, instead of upfront paying for a 3-year program, can we start paying for how far we're moving the indicators? I think it's a really important question. And although it's outside of the scope of this presentation, one of the programs we've worked on in Western Kenya as well since then, and how I really started with the company is linking safe drinking water and carbon on the carbon market. So can you pay for safe drinking water in the homes by offsetting the amount of water that has to be boiled by biomass? It's an innovative way of financing a program. We have distributed to 4.5 million people, nearly 1 million water filters under the first carbon finance program in the world to do this. It's very interesting, but as many of you may know, the carbon market has crashed. And so that particular model doesn't make sense anymore. But what does make sense is looking at the learnings. What you learn from that is we create carbon credits, or 1 ton of carbon, for the amount of behavior change you create at a household. How much people use the filter, for what purposes, how often they use it. You create a carbon offset that then has a sale value on the market. So while you have to upfront the cost, you get money back to sustain the program by changing behavior, by creating outcomes. And I think while it doesn't make sense for the carbon markets anymore, there's a lot of problems in the carbon markets, what we do need to think big. What can we learn about this in the development financing space? Can you create a market where instead of getting paid to deliver bed nets, or instead of getting paid to build a hospital or implement an HIV program, what about Dallies saved? Can you implement a program and then you get paid for all the Dallies saved that you can demonstrate, or all the lives saved you can demonstrate? And what does that mean? Is that a good approach? Is it different? And I think that's where the health economics needs to start really looking. What's the cost of changing our thinking like that? So just in terms of acknowledgments for the Kenya Integrated Prevention Demonstration research we did, we worked at a lot of universities. All of our economics work was with UCSF, Jim and Elliot being paramount to that. So thanks to them. The funding for all the studies came from the company itself.